Assalamu alaikum and good evening. It is, I think we should start on time because we have a lot of presentations today and some very exciting stuff coming ahead. On behalf of the Middle East North Africa Stroke Organization, it is my great pleasure to welcome all our renowned guests and delegates to the 6th chapter of MENASO Education Academy, the Cerebrovascular Grand Round 2022. It is endorsed by the World Stroke Organization and the American Stroke Association. And this Cerebrovascular Grand Round, for our regulars, they are well aware that it is a unique platform that provides comprehensive education about stroke, its latest treatment and management. The way, just a few housekeeping notes from me. My name is Dr. Maria Junaidi. I'm one of the members for the MENA Stroke Organization, and I'm a neurologist at Rashid Hospital. I will have a few introductions that I need to make before we start with our cases. It is my great pleasure to introduce Dr. Dirk Krieger. He's a professor of neurology at the Neuroscience Center at Mediclinic Dubai campus. He has received his basic neurology training in Germany and has subsequently worked in various centers, renowned centers such as the Texas Medical Center in Houston, the Cleveland Clinic Foundation, and also as the chair of cerebrovascular disease at Copenhagen, Denmark. University of Copenhagen, Denmark. He arrived in Dubai in 2015, and since then he's built a comprehensive stroke center at Mediclinic Dubai campus. He's very well known in our stroke community here, and we are very pleased to have him for his expert views today. Our next chair is Dr. Muhammad Al-Kuwaiti. He's a consultant neurologist at the Tawam Hospital, Al Ain, UAE. And he is also an assistant professor at the UAE University. He has more than 13 years of experience. He first did his internal medicine residency, and then this was followed by neurology residency at McGill and a vascular neurology fellowship program from the University of Minnesota. So thank you, Dr. Muhammad. It is again my great pleasure to have you here for your expert views on the cases. The third introduction that I should make is of Dr. Saeed Iqbal. He's a neuroradiologist at Rashid Hospital, and his basic training is from India, and then he did he's a fellow of Royal College of Radiologists of London, and he has a vast experience, more than 25 years of intensive experience in radiology with specializations in MRI and multi-slice CT scans. He's presently working as a senior specialist radiology in Rashid Hospital, and he's the backbone of our neuroradiology program. He is here as an expert commentator on some of the radiology that will be presented in the cases, and we are very grateful to Dr. Saeed for all his input today. So this is how it will work. I will pass on the podium to my two chairs, who will then introduce one after the other our case presenters, and then after a 15 or 20-minute case presentation, the audience can post questions related to that case, and we will have a short 5 to 10-minute discussion where we will try to address any queries that the audience might have, and before we move on to the next case. So I will hand over to Dr. Muhammad Al-Kuwaiti to start with the introduction for the first presenter. Dr. Kuwaiti.
Hello, everyone. Assalamu alaikum. And good evening to the MENASO educational session. So we're going to start with the first presenter. Our speaker is Dr. Shaista Siddiqi. Dr. Shaista is a specialist registrar in the Department of Neurology at Rashid Hospital in Dubai for the last 7 years. Before joining Rashid, she worked as a consultant neurologist and assistant professor at the Jinnah Medical College in Karachi. She achieved her neurovascular fellowship from the Aga Khan University in Karachi and Bachelor of Medicine from Doe Medical College. She is a reviewer in multiple journals, and also she did publish multiple studies, scientific posters, and platform presentations in her career. Please, Dr. Shaista, you can go ahead with your presentation.
Assalamu alaikum. Thank you for the kind introduction. It's my pleasure to be here today. I would start with my presentation. Let's start the slideshow. Okay. So basically, we will start with a case histories from our own patients from our hospital. This will be followed by a review of literature. There's no conflict of interest for the sake of this presentation. So here's a list of few abbreviations you will be seeing in the course of presentations. So our case one is a young Indian gentleman. He was 35 years old. He was not known to have any comorbids. He was last seen normal at 11 a.m. when he came back from his work. He was working at a hotel. He went to sleep and then he wakes up at 5 p.m. with right side weakness. So he was brought to the emergency at around 7:34 p.m. At the emergency, the examinations showed mild right hemiparesis of around 4/5 on MRC scale. The NIHS score was 2 at that time. As per the acute stroke protocol, he underwent a non-enhanced CT brain along with CT angiocerebral, and we'll be sharing the images after this. And he was out of the window for TPA, and also the NIHS was 2, so he was not offered TPA. And this was decided to put him on dual antiplatelet with the loading dose along with high dose statin. However, over the course of next 2 or 3 days, he gradually progressed in the neurological impairment. The hemiparesis became dense, about 1 to 2 in arm and leg, along with facial weakness and dysarthria, which persisted by the time he was discharged. So I would like Dr. Saeed to help us with these radiology images.
Okay, these are the axial brain sections. On the left side is the normal window. Just play the okay, and on your right side is an infarction window. Here you can see an area of low attenuation in the region of left posterior limb of internal capsule at the corona radiata, which is appreciated more clearly in the infarction window. So around, it was aspect of around 9. Rest of the territory was, there was no any altered gray matter differentiation. So we had given it as a small acute stroke with aspect score of 9. CT angiogram was done as a protocol. Next slide, please. Okay, we do multi-phase angiogram. This is on the left side is an angiogram phase 1, which showed bilateral normal carotid arteries. And as we go ahead, we see mild atherosclerotic thickening at the left carotid bulb. And the rest of the cavernous, the petrous portion and cavernous portion were looking normal, except for small calcification at the cavernous region. And we see a mild narrowing at the M1 segment of left middle cerebral artery. Similar narrowing was seen at the right M2 segment, just at the origin of the right superior segment. And so it was a mild disease, mild and the same thing on the coronal as we see. Mild narrowing is there with plaque at the left carotid bulb, mild narrowing at the left M1 segment, and another narrowing on the right side. So it was intracranial atherosclerotic disease with mild narrowing and an aspect score of 9 with a small acute infarction in the posterior limb of left internal capsule. Yes, Maria? Yeah.
This is the follow-up MRI.
The follow-up MRI showed a well-deformed infarct with the flare and diffusion. Both we see the hyperintensity at the left centrum semioval and the posterior of left internal capsule.
Thank you, Dr. Said. So he was discharged on dual antiplatelet based on the ICAD, and he basically repatriated, so we don't know about the follow-up of this patient. The second case we are discussing today is again an Indian gentleman. He was 54 years of age, again not known to have any comorbids, but later his workup revealed multiple comorbids. He was last seen normal at around 3 p.m. and then he woke up at around 5 p.m. after a short nap. He was seen in the emergency at around 9:18 p.m. On the examination in the emergency, the NIHS was 4 based on their mild right hemiparesis. He again underwent the same protocol with CT, unenhanced CT brain with CT cerebral angiogram. He was out of the window for IV RTPA, so he was offered mechanical thrombectomy. He had a groin puncture around 11:35, and he received TK3 within an hour. He improved after that within the next day, and his NIHS was 2. He was ambulatory independently, and he has a mild pronator drift on the right side only. So his imaging.
Again, the non-contrast CT brain with the infarction window on your right side. Here, it was a similar case with a low attenuating area in the left lentiform nucleus with old infarction in the left parietal lobe. The rest of the territory was normal. There was no hypertensive MCA sign. We could see a small, just hypoattenuation in the left putamen area with an old infarction in the left parietal lobe. CT angiogram was done, which showed as we go ahead, we are seeing bilateral common carotid arteries, which are nicely opacified. And as we go ahead, both internal carotid arteries in the neck were tortuous. We could see a small plaque at the origin of the left internal carotid artery. And as we go ahead, we can see the cavernous portion is looking fine. Just at the supraclinoid, there is a narrowing of the left ICA, followed by complete occlusion of the distal M1 segment of the left middle cerebral artery. There was complete occlusion, and same thing on the coronal. As we see, there is a plaque there, which Dr. Shaista is showing. There was mid-basilar narrowing also. There was complete occlusion on the left side, and we could see few intermediate collaterals because we are doing a multi-phase angiogram. Next slide. These are the AXIAL phase 2 and phase 3, which shows the occlusion associated with intermediate collaterals on the phase 2 and phase 3. So this was a distal left M1 occlusion with a small infarction at the left globus, the putaminal level, and atherosclerotic disease in the form of mid-basilar narrowing and a soft plaque at the origin of left internal carotid artery.
So again, he was offered dual antiplatelets in view of the ICAD he had. A risk factor modification was advised, and internal medicine was on board with us for offering secondary stroke prevention measures. He was seen once after the follow-up, and he was doing fine, and he would be following the medical team for further risk factor modification. So in view of these two patients, almost similar in their clinical characteristics, low NIHS and similar mechanism of stroke, large vessel occlusion, we will be discussing role of mechanical thrombectomy in the large vessel occlusion in patients with low NIHS in acute ischemic stroke. So it has been said that the proximal large vessel occlusion is present in up to 30% of the minor strokes. Of these, almost 20 to 40% of these patients later decline neurologically, and similar is the case with the patients who have TIA as well, especially who have with a high ABCD2 score. In patients who present with NIHS less than 5, the poor 90-day outcome has been shown that the median NIHS is almost 3 points higher at 90 days. This indicates that even a small shift of the number in the NIHS in the initial period, acute period of ischemia, can result in a better outcome at the 90-day traditional mark for the gauging the outcome in ischemic stroke patients. Presence of large vessel occlusion, however, is a better predictor of outcome if it is treated well, and also early neurological deterioration can be minimized if the reperfusion has been set in time. Till date, the American Heart Association gave a level 1 evidence for performing mechanical thrombectomy for patients who have an IHS above 6. This is because most of the patients enrolled in the RCTs had higher scores. Only few of the patients in the Mr. Clean trial had an IHS as low as 2. Some of the prior studies did attempt to address outcomes with the mechanical thrombectomy, endovascular intervention in milder stroke patients, but there is a lot of heterogeneity, single cell reporting, retrospective data collection, a lot of other things, biases in those things. We will try to go through some of those. So there are some indices for the checking the improvement in these patients. Most common outcome which all the studies gauge is the modified Rankin score at 90 days. There are some other studies which have addressed the concept of rapid or dramatic or early neurological improvements, and hence you will see the delta changes or shift in the NIHS in some of these reported studies. One of those is a diffuse 3 cohort reported by the Heat et al., and they showed that the rapid neurological improvement in the diffuse 3 cohort was seen in about 1/3 of those patients. And this they also said that the mortality as well as lower median as well as the hospital stay was shorter in the patients who had rapid neurological improvement, and this was associated with the higher rates of TK2B3 reperfusion. So a successful reperfusion was associated with rapid neurological improvement, and hence the authors concluded that if you see RNI following endovascular intervention, favorable clinical and radiographic outcomes should be anticipated with a shorter in-hospital stay as well. Another group studied patients with low NIHS less than 6 and with a good aspect score of 9, and they measured the collateral score as well. Median collateral in their cohort of 41 subjects was around 2.3, that is around 50 to 200% collateral presence, and they showed that the absence of collaterals correlated with a larger finite infarct volume, and that was obviously associated with the worse long-term functional outcome. This is a large group of Italian comprehensive stroke centers, 9 centers, and they had a big group of patients who underwent mechanical thrombectomy for low NIHS under 5 with the anterior circulation large vessel occlusion. They reported a good primary outcome, that is MRS-021 at 90 days in about 80% of these patients, and they showed that the potential benefit. They showed the potential benefit of mechanical thrombectomy in patients with large vessel occlusion, especially the anterior circulation, who present with the low NIHS less than 5. Another study which was single-centered but has a good number of patients, 95, and they reported patients with anterior circulation large vessel occlusion and ischemic stroke, NIHS less than 8. They showed a good excellent outcome, that is MRS-021 in more than half of the patients, and together with a favorable outcome of about 70% and above. Both excellent and favorable outcome together, like MRS-022, was shown with successful recanalization rate. So more than 3/4 had an excellent outcome and favorable outcome with successful recanalization. So the authors managed to say that if you have patients with NIHS less than 8 and you have successful recanalization, there is a good rate of excellent outcome at 3 months. This was a Swiss stroke registry. Again, they screened patients over 11,000 patients. They screened, and they reported about 312 patients, and they showed a non-significant trend toward a higher MRS score at 3 months for patients who underwent endovascular therapy. They also showed a higher mortality rate with endovascular therapy for about 9.3% in endovascular group versus 2.8 in the intravenous thrombolysis group, and slightly higher SIH symptomatic intracranial hemorrhage rate as well, though the intracranial hemorrhage rate was non-significant. The authors concluded that this study provides class 3 evidence that patients with large vessel occlusion presenting with mild symptoms can receive either endovascular or IV thrombolysis therapy with similar functional outcomes at 3 months' time. Another big group, 4 French prospective clinical registries from comprehensive stroke centers called the ATIS registry. Big number of patients, about 300 patients with anterior circulation, large vessel occlusion, including M1, M2, ICA, cervical carotid, and the tandem occlusion. And again, NIHS less than 8. Their patients had a median aspect of 9 versus 8 in the medical versus mechanical thrombectomy group, and the median NIHS was about 3 versus 5. About a quarter of patients with medical therapy had a rescue mechanical thrombectomy because of neurological worsening, and despite this, excellent outcome was seen in about 65% of cases, which was similar in medical and mechanical thrombectomy group. The favorable outcome, that is MRS 0 to 2, was a little bit more in the mechanical thrombectomy group. The author concluded that the minor to mild strokes, that is an IHS 3 to 5, with large vessel occlusion in the anterior circulation, achieved excellent and favorable functional outcomes at 3 months with the mechanical thrombectomy. Amru et al. Again, they had a big group of 214 patients studying the anterior circulation group, and they also they showed a little bit different results, that patients with M1 group have some improvement with the mechanical thrombectomy. However, there was no improvement in excellent independent functional outcomes in the middle stroke NIHS less than 6, and they showed a little bit more SICH and mortality rates in the endovascular therapy. Again, this a big group from the Chinese centers, 100 plus patients. They showed the small infarct core and MT treatment were independently associated with the excellent outcomes. Mechanical thrombectomy with mild symptom, again, they showed the acute large vessel occlusion in anterior circulation can have clinical outcomes which are favorable.
2 minutes, Dr. Shaista.
I think there are a lot of, I would like to take you to a table which I tried to make from my own studies. So if you see all these studies, almost 12 or 13, they are recent. They are from 2016 and till 2022. They have studied large vessel occlusion, including anterior and posterior circulations. But most of these are retrospective data. A few of them are large databases, including Swiss registry, ATIS registry, French registries. One of them is from the SWIFT registries, and also they have NIHS from 8 to 5, anywhere from 5 to 8, and they have showed favorable results in terms of mechanical thrombectomy, apart from a couple of studies which showed equivalent results, not inferior for mechanical thrombectomy, and they have studied mostly modified Rankin at 3 months. So this is a meta-analysis, and they came to the same conclusion because of the heterogeneity and different sample sizes and designs. It's still the role of EVT is not to be generalized in overall population. So in conclusion, mechanical thrombectomy in mild strokes are mostly taken as an IHS less than 6. It is still ambiguous. We have some scarce data. We have some data supporting mechanical thrombectomy, but to go into the guidelines, they still take a few randomized controlled trials. And we are looking forward to the results of the ENDFLOW and the minor stroke therapy evaluation. The recruiting is still going on, and we hope that by next year we will have results from these 2 major trials, and we will have some answers regarding the role of mechanical thrombectomy in low NIHS patient in acute ischemic stroke. With this, I am thankful to you. I hope I did in time.
Dr. Shaista, thank you. That was amazing. You compressed a huge lot of data in like a few minutes. Wow. Mashallah. Just to summarize, you presented 2 cases just for the audience. The first one was a young 35-year-old presenting with NIH score of 2 and intracranial stenosis, and was managed medically with antiplatelet and risk prevention. And the second case was a case with an M1 occlusion on the left side with NIH score of 4. Which is a low NIH, and you performed a mechanical thrombectomy, and the patient was discharged with a low MRS score. These are interesting, challenging cases, especially the second case. I actually have a question I'd like to ask you. For reviewing the literature, did you like build up a criteria, or how would you characterize patients with low NIH and intracranial occlusion? How would you categorize them? Would you look at CT perfusion? Would you look at collateral, MRI score before, the disability, prior strokes? Like in our case, he had prior strokes. What are the criteria that would you evaluate before you advance with mechanical thrombectomy?
Okay, so the things which help us to decide for whether to go for intervention or medical.
Yeah.
Yeah. So we don't have perfusion in general in our hospital setting. We go with the angiograms. So if there's a large vessel occlusion with low NIHs, we discuss the whole profile of the patients. So as seen in the review of literature, there are certain things which have shown to have sometimes non-significant, sometimes significant trend towards favorable outcomes, like hypertension, like patients who have M1 occlusions, patients who have cardioembolic strokes, patients who are young, patients who are having a short window from onset to groin, and especially when you have you have a good expertise in the endovascular treatment, like we are blessed to have good interventionists with us, so they have good hand. In those cases, we go for the intervention.
Okay, so I'd like to add to your comment. Having CT perfusion will be very helpful so that you can evaluate the core and the penumbra. Knowing the patient MRI score before you intervene. Let's say patient MRI score is 4. And would you intervene in such case? The studies, they looked at cases that showed benefit where MRI score 0 to 2. Maximum was 2. Before the procedure, you would assess the disability of the case. So in summary, it will be like case by case basis.
Sure. Highly individualized cases. And most of the studies have actually excluded patients who have premorbid MRS less than 2, more than 2.
Yeah,
so they have a very selective criteria. If you closely look into the inclusion criteria, they have chose a very neat and clean sort of patient with an aspect around more than 8 or 9, NIHS less than 5, premorbid MRS less than 2. Very clean patients they have selected for low NIHS subjects.
So in your institution, so to be able to address these cases, it'd be good to have a criteria like in your system where you can look at these patients and characterize who will benefit, who will not benefit by using looking at risk factors, disability, MRI score, CT perfusion. That will be helpful because we don't have enough data in the literature. What you presented were case series and case reports, and there's a review of these case series, but the high rank evidence, which is the randomized controlled trials and systematic analysis of these RCTs are not available. Hopefully in the future we'll have an answer, but up until then it's inshallah case by case basis. Yeah.
In our institution, we are following our patients. We have a regular MT meetings every 15 days. So for last few months, we have been keeping a check on these patients. So hopefully we will be presenting in next meeting or so.
Can I add something just quickly? A very nice presentation, Shaista, and very good work, firework of presentation, I must say. Both of the cases that you show are very similar. And what you haven't alluded on was the medical treatment. The first patient who did not receive any endovascular therapy, which was probably a good idea, worsened secondarily, probably because of a reduced collateral flow and maybe blood pressure reduction, whereas the second one, who you treated with endovascular therapy, didn't have the chance to do that. The second case, you saw an occlusion and you said, okay, I'm not sure that this collateral flow is gonna keep up, and so we better take care of this clot. And then we have a little bit more liberal management of the blood pressure. Whereas if you keep it the way it is, you really have to keep the pressure up. And that is sometimes a problem if you, put the patient in an ICU and different teams come and different blood pressure managements are being performed. And so I think this is what you really have to look into in these cases, that you really have to standardize the blood pressure management and the aftercare in these patients.
Agree.
Great. Thank you, Dr. Derek. Thank you, Shaista.
Thank you so much.
Speaker. I'll move the mic to Dr. Derek to present the next speaker.
Yes, thank you. Thank you, Doctor. So I would like to introduce Saba Farooq. Dr. Saba Farooq is a senior resident neurologist at Rashid Hospital in Dubai. She has completed her graduation from Dow University of Health Sciences in Karachi, Pakistan in 2012 and achieved Saudi board certification in neurology in 2021. She cleared the specialty certificate examination in neurology in 2020, also from the UK. And Dr. Saba has 9 years of experience, including the participation in research and publication and conferences. She's also a member of the American Academy of Neurology and the World Stroke Organization. Dr. Saba, the floor is yours.
Thank you, sir, for the kind introduction. So I'll be presenting today the second case. I'll start. My patient is a 46 years old male. He's a known case of diabetes and he's on oral hypoglycemic agents. He's a chronic smoker. He presented to the emergency department with the sudden onset of right-sided weakness associated with facial deviation and slurring of speech. On examination, he was vitally stable. His blood pressure was 134/77. He was alert. His positive findings include the right upper neuron facial palsy, severe dysarthria, right-sided upper limb dense hemiplegia, and the lower limb power was 3, which makes his NHS score of 10. So he was last known well at 12:30 a.m. He was found to have weakness at 4:30 a.m. He reported to our hospital at 7:23 a.m. and he was seen by the neurology around 7:45 a.m. So almost he has passed 8 hours. He was taken for the CT brain and CT angiogram as per the stroke protocol. This is his CT brain, non-contrast axial view.
There are 3 panels with the CT brain, CT angiogram, axial view, and the coronal views. As we see in the CT brain, there is an area of low attenuation as we go towards the basal ganglion region, obscuring the left lentiform nucleus, as we can see there. And as we go up, there was again in the left frontal operculum. Yeah, that's the loss of gray white matter differentiation was there. So we gave the aspect of 7 to this patient, and CT angiogram was done, which showed now we can see the both carotid arteries in the neck appear normal. And as we are approaching towards the intracranial portion of the carotid arteries, we could see there is a proximal occlusion of the left M1 segment of the middle cerebral artery that can be clearly seen on the angiogram. And there were very few collaterals there. And so basically it was a large vessel occlusion of the M1 segment of the at the proximal level with aspect score of 7.
Okay. So what should we do next? He's a young man who presented with a dominant hemisphere infarct, 8 hours from the last seen normal, almost has passed 4 hours from waking up, aspect score is 7 and NIH is 10. We have few options. Like we can go for the MRI, looking for the DWI FLAIR mismatch as in case of a wake-up stroke, which tell us about the time window. We can go for the CT and MR perfusion, and on the basis of the dawn and diffuse triad, we can take the patient for intervention. And our third option is MRI brain, looking for FLAIR vascular hyperintensity and DWI mismatch, or DWI and SWI mismatch.
So this is MRI brain. These are the FLAIR on the left side and diffusion on the right side. As you can see, there was area of diffusion restriction in the left lentiform nucleus going towards the left corona radiata, with few areas of focal restriction in the left parietal lobe. But as you see, there was no much hyperintensity. Saba, please can you go back little? Yeah. And there was no much signal change within the left on the FLAIR sequences. So this was a case of FLAIR diffusion mismatch, only subtle we can see, but it was not that appreciable. So there was a FLAIR diffusion mismatch, which showed that probably the stroke is within the 6 hours of time window. Then we go to the next slide, please. This is the reason why I'm showing this one is FLAIR vascular hyperintensity. This is an area of hyperintensity which is seen in the horizontal segment of left M1. In the Sylvian fissure, we can see multiple areas of hyperintensity along the cortical sulci in the FLAIR weighted image, which are beyond the boundaries of what we see in the diffusion weighted sequence. So this is called as FLAIR vascular hyperintensity diffusion weighted mismatch. So these are the slow flow vessels which are seen either due to proximal occlusion, either it shows intraluminal thrombus, or slow retrograde flow within the leptomeningeal collaterals. So that's the reason which we are showing that there is a FLAIR vascular hyperintensity that are the vessel hyperintensities seen along the cortical sulci. Next slide, please. This is now DWI, SWI. This is a susceptibility weighted image where we see multiple prominent abnormal veins which are marked there, which are tortuous and seen beyond the boundaries of the diffusion restricted area. We are not seeing any area of diffusion restriction at that place. So these are abnormal prominent veins in the left cerebral cortex, mainly in the area of left M2, M3, M4. So this is called as DWI, SWI mismatch. These two things, FLAIR vascular hyperintensity and DWI, SWI mismatch, are beyond the boundaries, and they show us that these are the large area of ischemic penumbra in absence of non-availability of the CT, which Dr. Saba will discuss more in the slides. So this is, I think after this, the decision of thrombectomy was done, taken. We can see the pre-thrombectomy, the DSA study where it shows complete occlusion of the left proximal M1 segment. On the post, it was aspiration, and TK3 result was achieved with complete recanalization of the left middle cerebral artery. The follow-up FLAIR diffusion, again, we can see which was the follow-up MRI was done, which shows there is a FLAIR and diffusion hyperintense signal at the area which was there with small speck of hemorrhages within it, but there was no expansion of the infarct. Infarct growth was not there. So whatever was seen on the FLAIR diffusion before, almost limited infarct residual we can see. So this is the way to select, can be an alternate way to select the patient for endovascular treatment in absence of CT perfusion.
So as Dr. Sai said, it on the basis of this mismatch, we took the patient for the intervention. The patient improves clinically. His NIHS score at discharge was 6. His dysarthria improved significantly. He had a mild right upper motor neuron fissure palsy, and he was mobilizing with support. So what does the literature say about this? This article was published in 2019 about the FLAIR vascular hyperintensities. They have reviewed around 100 patients with proximal MC occlusion from 18 stroke centers. So they include the FLAIR vascular hyperintensity is basically a circular or serpentine brightening in the brain parenchyma or the cortical surface bordering in the subarachnoid space on MR imaging. The FLAIR vascular hyperintensity and DWI mismatch is defined by the FLAIR vascular hyperintensities, which is FVH, located beyond the boundaries of the DWI lesion and is associated with large penumbra. Among stroke patients with proximal middle cerebral artery occlusion referred for thrombectomy, those with FLAIR vascular hyperintensity and DWI mismatch are likely to benefit from revascularization. FLAIR vascular hyperintensity and DWI mismatch provides an alternative to perfusion weighing image and DWI mismatch in order to select the patients who are actually the candidates for thrombectomy. This is another article about FLAIR vascular hyperintensity and DWI mismatch published in 2020. They have reviewed around 72 acute stroke patients, and they have divided the patients into two groups. One group has actually the FLAIR vascular hyperintensity and DWI mismatch, whereas the other group doesn't have the mismatch. And on their result, they can clearly seeing that the patients who have the mismatch have higher rate of complete revascularization, as well as they have a good functional outcome in 3 months. This article is about the asymmetrical prominent veins or SWI. They have reviewed it around 20 patients, and they concluded as asymmetrically prominent veins are a sign of reduced cerebral blood flow perfusion. A positive DWI-SWI mismatch is a sign of salvageable brain tissue. A positive DWI-SWI mismatch is a predictor of an overall increase in infarct size. This is another interesting article published about SWI and DWI mismatch, where they have reviewed around 52 patients. Now I will request again Dr. Saeed Iqbal to please highlight the importance of these images.
Yeah, as we can see on this panel, there are the 4 images: diffusion weighted image, then the SWI, and then there is MR perfusion and the fusion image of SWI and the diffusion. There was an area of diffusion restriction. As we see asymmetrical prominent veins on the right side on SWI as compared to the left side, which are showing in the area of perfusion as a large area of increased mean transit time. And in the fusion, we can say that exactly it was the same area which was there showing an abnormal or asymmetric prominent veins on the right side compared to the contralateral side. So this gives us an idea that these are the area which are of salvageable tissue on the basis of availability of this asymmetric prominent vein, because the pathophysiology shows that it is the basically paramagnetic substance of deoxyhemoglobin which has been seen by the SWI, which is very sensitive for this product. Same is down, we can see area of diffusion restriction, abnormal asymmetric prominent veins on the right side, and then we can see a large area of perfusion defect with a mean transit time increase. And on the fusion image of DWI and SWI, we can see that that is the same area which is showing abnormal prominent veins. So we can conclude that this can be a strong alternative in non-availability of the MR or CT perfusion and automated softwares which are available so that we can use it. Yes, Saba.
So this article actually concludes that among patients with acute cerebral ischemic stroke, the sign of reduction in the cerebral perfusion pressure is due to the increase in the proportion of deoxyhemoglobin and oxyhemoglobin caused by the increase in oxygen extraction fraction. The SWI is basically a high-resolution T2 MR technology with a 3-dimensional gradient echo. Since the SWI is very sensitive to the changes of oxygen extraction factor of deoxyhemoglobin, SWI can provide a similar metabolic capability to MTTs, which is the mean transit time. Okay, so the take-home message is, in cases of non-availability of the perfusion imaging, FLAIR vascular hyperintensity and DWI or DWI-SWI mismatch on MR imaging can serve as a viable indicator of ischemic penumbra. It has been shown to predict infarct expansion and can guide for the endovascular treatment decisions. That's it. This is from my presentation.
Very nice. Thank you. Thank you, Saba.
You're most welcome, sir.
Let me just ask one question, and then there's a question from Mohamed Al-Mersa, which I think is very interesting. And it says that in your case with DWI FLAIR mismatch, if mechanical thrombectomy would not have been available, would you have gone for IV thrombolysis in this case?
Okay, for IV thrombolysis, why we haven't given in our patient? Because even from waking up till the time MRI has been done, 4.5 hours of window period has been passed. If the patient is within the window period of the 4.5 hours and there is a mismatch of FLAIR and DWI, we would have given him the IVTPA.
Okay. So in this case, you would have. Because
yes. But he has already passed 4.5 hours, even from waking up also.
Yeah, but that was the question. What if, the same case, you wouldn't have had a mechanical thrombectomy? Would you have given him IVTPA because of the mismatch, or would you have not?
No, because he has already passed the 4.5 hours from waking up.
You go by the chronological time. Very good.
Yes.
So just to clarify, I mean, I understand that this was a case where you started out with a CT and CT angiogram to see the large vessel occlusion, and then you ended up switching the patient to an MRI, which is a lot of time lost. I think you have to decide. I mean, I know why this is done in these cases, case by case, but I think for the audience, the 2,500 people listening to us, I think you need to decide whether you go with CT or you go with MRI. I think switching is a difficult issue. So when would you go with an MRI and when would you go with a CT scan? Can you help me?
So in the CT brain, as you have seen in our case, the aspect score is very good, and the patient is having the proximal MC occlusion, the proximal anterior circulation occlusion. So he's a good candidate for the thrombectomy. Whereas if supposedly we have a patient whose aspect is poor, like for example 3 or 4, and he doesn't have a proximal anterior vessel occlusion, then we would have not taken the patient for the MRI brain.
Okay. How would you have handled a case in the posterior circulation? Basilar.
Okay, so still the guidelines are not recommended for the Dawn and Diffuse trial are also for the anterior circulation occlusions. So still we don't have a lot of literature available. However, the new trials are coming up which are supporting the posterior circulation stroke thrombectomy cases. But beyond the window period, still we are not very clear. So we are not doing it for the posterior circulation stroke currently.
Okay. So there is some experience with cases that we have treated under me, and it is clear the MRI has a better resolution in the posterior fossa than the CT scan, simply because of all the bone artifacts. And so if you have a case with a basilar, it's always a good idea to get an MRI, just as a DWI, and see how the brainstem is affected, because the basics study is definitely a very negative trial, and it is because the damage has already been done when these patients are being thrombectomied. And so I think when you have a basilar, try to go for an MRI, because it really gives you important information that you can immediately put into the clinical practice. So
I think more recent data, Dr. Dirk, is actually supportive of interventions, even based on CT aspects in the posterior circulation. The attention study, which was just presented at the European Stroke Organization conference, is actually supportive. The problem is that the definition of a good functional outcome for posterior circulation can be very different from the definition of a good functional outcome in the anterior circulation. So I think that's where the catch is. And in terms of CT aspects, we need to see, because aspects is tricky even for anterior circulation. The inter-rater reliability is not much more. And that's where you're very right that an MRI could help. Unfortunately, at our center, we can get a CT much more timely compared to an MR, and that's why we kind of first do the CT on arrival and then move on to MR.
Well, Maria, I fully understand, and it's just that I wanted to make sure that the audience understands that it is not a good practice, to switch from modality to modality.
Yeah.
Workup. You should decide.
But there's promising data in posterior circulation interventions now, I think.
Good. I think we need to move on.
Yes.
And I would ask Dr. Al-Kuwaiti to present the next speaker, please.
Okay, great. Thank you, everyone, and thank you, Saba, for the presentation. Just for the sake of time, we'll move on. So our next speaker is Dr. J. Perkash. Dr. J. Perkash is a specialist neurologist at the Department of Neurology at Rashid Hospital, Dubai for the last 6 years. Before joining Rashid Hospital, he worked as an assistant professor of neurology and consultant neurologist at the Doha University of Health Sciences, Karachi, Pakistan. He completed his Bachelor of Medicine and Bachelor of Surgery from Sindh Medical College at Karachi. Dr. J took medicine residency training and neurology residency training at the Civil Hospital at Karachi in Pakistan. Dr. Jay will present our third case today. Please go ahead, Jay.
So she was 37 years female with no previous comorbidities except smoking. She presented with a history of fall for 1 week. For that, she visited different health facilities with headache and the vomiting, and she was advised to do the CT scan brain, but she could not do because of the financial issue. She came to the emergency department, Rashid Hospital, with increased headache and vomiting. In the emergency, on the examination, she was alert, oriented, with no aphasia, no dysarthria, no neck stiffness, cranial nerves were normal, no motor deficit, and CNS, actually neurological examination was normal. We had a CT brain, and I would like to ask Dr. Said, please give the comment.
Yeah, the non-contrast CT brain was done as the history of fall was there 1 week prior, which here we can see the CT brain, the posterior fossa looks unremarkable. And as we go in the supratentorial compartment, there is a mild to moderate amount of subdural hematoma in the left cerebellar convexity all along from the frontal temporal region with gray-white matter differentiation buckling, minimal mass effect. So, and on the bone windows, there was no skull fracture. This was an acute subdural hematoma in the left cerebral convexity and without skull fracture with minimal mass effect. Yes, please, Jay.
Yeah, thank you. So she was admitted under the neurosurgery department because of mild hematoma and no significant mass effect. She was admitted under the neurosurgical department and the conservative management was opted. 3 days later, the assigned nurse noticed that she was behaving abnormally. She was not speaking and aphasic, and she had the right-sided right arm weakness. Urgent CT was done, and again, I would ask Dr. Said, please.
So this was a repeat CT scan which was done after 3 days. As we see, the posterior fossa looks normal, and as we go in the supratentorial compartment, the hematoma almost looks similar. But now a new finding is that we are seeing an area of all low attenuation in the left MCA territory with loss of gray-white matter differentiation with increase in the mass effect.
So she was taken for the urgent surgery and craniotomy was done, and with evacuation of the subdural hematoma. Post-operatively, she was alert but aphasic and with no gross motor deficit. No improvement in the aphasia over the subsequent day, and she had a post-operative CT scan brain. Please, Dr. Said.
Yeah. So this is the post-operative CT scan, which shows a nice evacuation of the left subdural hematoma by craniotomy, and we can see a well-established infarction in the left MCA territory all the way till the M3, M4 region and involvement of the left basal ganglia. So it was an acute left MCA infarction, which happened, the event took place within this 3 days at the time of before the operation. So it was a well-established left MCA infarction.
So neurology had seen first time and advised to a stroke workup, and we did the CT cerebral angio. Dr. Said, please.
Yeah, this is the axial CT cerebral angiogram on the phase 1. As we can see, normal appearing bilateral carotids. Both the vertebrals are also looking fine. And as we see, just at when the bifurcation, the caliber of the left internal carotid artery starts narrowing, and in its whole entire cervical segment of the left internal carotid artery, the lumen is narrowed, and it is, we can see that the flow is also slightly reduced. As we go in the cavernous portion, we can see a narrowed lumen with significantly narrowed supraclinoid portion, with not visualized left MCA in its segment, and multiple collaterals are there. We can also see multiple collateral vessels along the left cerebral convexity. So this was diffuse narrowing, which was seen in the left middle, the left internal carotid artery, which was seen at left M1 segment, was significantly narrowed, associated with multiple collaterals. We could see all along the left cerebral convexity. Even we can see some areas of narrowing were there in the proximal segment of left PCA, as well as on the right side in the M2 branches. So we kept a possibility of an vasculopathy in this case, with no evidence of any atherosclerotic disease in the aorta. Next slide, please. Yeah.
So now our consideration. So she had the non-fractured subdural hematoma, and she's having arterial ischemic stroke with underlying narrowing vessels due to vasculitis. So what are the considerations and how to proceed? So possibly we'll discuss with the radiology and the neurology team. So possibly she's having chronic underlying process leading to the MCA narrowing, and she's having collaterals that are the well developed, and probably her trauma with the large subdural hematoma without the fracture gave her the bleed, and her bridging veins were likely engorged, and the stroke is possibly because of the compromised collaterals. So now then we opted for the MRI brain. So again the discussion were to either we need to proceed for the DSA or the MRI brain and the MRA plus vasculitic work protocol. DSA in this case, patients having few severe financial issues, and although we wanted to see the lumen and plus the wall thickness and the enhancement. So with your discussion with the team and the radiology team, so we opted the MRI brain and with the MRI vessel wall angiogram. So Dr. Said will please proceed.
Yeah, this MRI was requested with, we were doing MRI brain with MRI vessel wall imaging protocol we used. This is a FLAIR and diffusion, which shows a fully evolved left MCA territory infarction along its cortical. Basically, it was cortical infarct involving whole territory of left MCA with the residual subdural hematoma even going to the right side. So this was the well-established infarct was seen very well on the FLAIR and diffusion. Next slide, please, Dr. Jay. Next slide. Okay, now just before I proceed to this slide, just stop for a while. This is a multi-parametric. We do high resolution 3D weighted T1 fat suppressed pre and post contrast imaging for vessel wall. So this is an 0.5 millimeter thickness images which we take in pre and post contrast phases at the same level and see the pattern, how the wall is and how the enhancement of the wall pattern of the vessel wall is. So go ahead, Dr. Jay, please. So as you can see in the pre-contrast study, there was a severe narrowing of the left internal carotid artery. And as we see in the post-contrast, where the cursor is going, there is a diffuse, concentric, smooth enhancement of the wall of the left internal carotid artery. We can see as compared to the right side, whole of there is a concentric, well-defined enhancement is there. There is no much of the perivascular enhancement, and the enhancement is seen also along the cavernous portion as compared to the right side. And it is even the enhancement of the wall is seen in the proximal left M1 segment. So there was a smooth concentric enhancement of the wall of left internal carotid artery, mainly in its distal and cavernous portion associated with enhancement of the left M1 segment. So this was the finding which we got in a patient with this one. Next slide, please. These are the coronal and sagittal reconstructions of the same 3D weighted post-contrast T1 fat suppressed. We can see on the left and right how nicely it is showing a smooth concentric enhancement of the wall of the left internal carotid artery as compared to the right side. You can see that there is a real difference is there on the coronal weighted image. As we can see all the way down, it's going towards the cervical segment of the left internal carotid artery. The lumen is narrowed So here we can say about the wall of the vessel, as well as we can see that there is a narrowing of the lumen. On the sagittal reconstruction, as we can see, as we go towards the left side, same diffuse enhancement, which is nicely seen along the wall, concentric, smooth, no evidence of any eccentric enhancement, no evidence of any cap or any double lumen is seen. So this was a classic case of an where we see the enhancement of the wall nicely on the sagittal and post contrast images. Next slide, please. Next slide, Jay. This is a time of flight MRA just to complete the study, and this is 3D PD T2 weighted images. The same parametric imaging. This will help us to show how the morphology of the wall is, and is there any element of T2 hypointense cap which is seen in the atherosclerotic disease, or is there any intramural hematoma that can be seen. As in the time of flight, we are seeing narrowing of the vessel, and as we can see, there is left M1 segment narrowing is there, just to compare, and multiple collaterals as are seen on the PD weighted images. So this T2 or PD weighted 3D images will show you the morphology of the vessel. Yes, Dr. Jay. Next slide, please.
Yeah.
Yeah, that's okay. Yeah, okay. Now, again, this is from the literature review, which shows these are the images of time of flight MRA, and down is the vessel wall imaging. As we see on the right side with the arrow there, we can see that there is a narrowing of the M2 segment, and we can see the vessel wall enhancement, which is smooth, concentric, and nicely seen. Same images are there on the in the mid pictures of the basilar and the anterior A1 segment, smooth concentric enhancement of the walls. And again, on the last slide, we can see that there is enhancement of the supraclinoid portion of the both carotid arteries. So this was, we gave a diagnosis of acute inflammatory vasculitis in our case on basis of the vessel wall imaging and the other additional findings. This is a table which shows that how the vessel wall imaging can help us to decide and to differentiate between vasculitis, atherosclerosis, intra-arterial dissections, and RCVS, which are the main thing. And obviously, Moyamoya disease and Moyamoya patterns are there. But to differentiate between the vasculitis and atherosclerosis, we can see that the enhancement is thickened, the wall is thickened, concentric, vivid enhancement is there. Whereas in atherosclerosis, we see eccentric thickening and enhancement is eccentric. And over that, we can see in the lumen or at the wall, the fibrous cap and the lipid core, which can be seen on the T2 weighted images, which can help us with the help of vesicular vascular imaging. In the patients of dissections, we can see the signal characteristic of blood products in the wall, that is intramural hematoma, that also will be thickened and eccentric with the signal changes, and the enhancement will be focal. So that will also help us differentiating the what is the cause of the narrowing of the vessel. In RCVS, there is no much enhancement, as this is a reversible condition, and we get multiple areas of stenosis, and mainly the posterior circulation is often involved. Same is the case with the Moyamoya disease. We don't get enhancement, but in the vasculitic pattern of Moyamoya disease, or Moyamoya syndrome, we have vivid concentric homogeneous enhancement with the thickened eccentric wall, not the concentric wall. The concentric wall thickening, concentric enhancement is a feature of acute inflammatory vasculitis or primary angiitis, as we can see. Thank you, Jay.
So we did the other workup to rule out the systemic vasculitis. So viral serology were negative, ESR was 43, CRP was 14, and the ANA, anti-double-stranded DNA, rheumatoid factor antibodies, ANCA, and all the vasculitic workup were negative. Transthoracic echo was also normal. So we labeled her the diagnosis as a case of primary angiitis of the CNS, and IV methylprednisolone was given for 1 gram daily for 5 days, and she improved clinically, and her discharge status was she was fully ambulatory with partial Broca's aphasia, and she was discharged early on her request. And then our plans to review her the clinical status, and possibly we need to accordingly we need to see the treatment or needs of the escalation of the treatment or not. but she lost the follow-up, so we cannot follow her. Take-home message: CNS vasculitis is a devastating disease, hence high index of the suspicion, and the timely treatment is warranted. MRI vessel wall is an emerging tool in the differentiating with the different intracranial pathologies. The hallmark of the CNS vasculitis on vessel wall MRI is concentric vessel wall enhancement of the intracranial arteries, often multifocal, with variable associated luminal stenosis and the wall thickening. It also helps us in differentiating with the vasculitic mimickers. It also helps us in the allocating the site to take the biopsy. Thank you very much.
Thank you, Jay and Iqbal for the third case presentation. You know, this case I think requires a much longer time to discuss. Actually, it's a tough case, and it was too fast for my brain cells. You know, I was thinking of this case, and coming in with subdural hematoma, and then developing an infarct. And then being diagnosed with the vessel wall imaging as vasculitis. I was wondering if sometimes we do other tests, like we do other evaluations like CSF evaluation, cerebral angiogram, looking at like a DSA to look at specifically at these small vessels. And also, we sometimes, if you already did a neurosurgical decompression, was there any biopsy taken, any tissue evaluated?
Actually, at the time of the the subdural hematoma, they didn't consulted us. So so they were considered that it's a subdural hematoma, and probably there is a mass effect, and that's why she deteriorated. So we reviewed the CT brain, and then we found that she's having a stroke. And the other thing is CSF is very important in differentiating there are the mimickers, vascular. We need to rule out the infectious causes. So, but we offered for her, but family refused for it. And again, for the DSA, she's having a significant.
I don't hear you.
One minute. Hello, can you hear me, sir? Hello.
Not sure. I don't hear you very well.
Jay, yes, we hear you. Continue. Yes, Muhammad.
Yes.
Okay, maybe it's my.
CSF is very important in case of the vasculitis, because we need to rule out the infectious causes, and also very important in vasculitis because there is a mild raised in protein and mild lymphocytic phagocytosis, and we've offered them, but patient and family refused for it. Again, for the DSA, because of large vessel vasculitis, we discussed with the radiology team and our team. DSA is good for the luminal, but we wanted to see the wall thickness and wall enhancement. So we discussed this thing with the radiology and the family, and we decided to go for the MR vessel wall imaging because this is a new and emerging tool, and that helps us to differentiate the vasculitis with other causes of the CNS vasculopathy.
I have one more question I'd like to ask. Did this patient have any prodrome, headache, like for several months, or cognitive impairment?
She was fine. Yeah, she was fine. Apart from this, fall, and then all the things came up.
Okay.
Normally this is vasculopathy presented with the progressive headache, the focal neurological deficit, the cognitive impairment, but actually she just fall, with fall, everything came up.
There's a question from the audience here. Why not thinking of like post-operative complication, like the same side of the SDH?
Yeah, it's one of the possibility, but if we look at the subdural hematoma, there's on the subsequent CT scan, we could not found the significant increase in the hematoma size. And second thing, if we look at the CT cerebral angio, there is a the narrowing of the internal carotid artery on the left side and the MCA also. So and with enhancement of it. So that's why we decided for the vasculitis. So the possibility was there, but CT cerebral angio findings were different from the findings we were expecting for the subdural hematoma compression.
Okay, so one more question, Jay, from Muhammad Al Mirza. He's saying, hello, could the cause of infarction in your case be due to vasospasm?
Yeah, this is the one of the possibility we were thinking. See, this patient had this is our one of the thought that he is having this compromised MCA, and with the collaterals, with the fall, things comes up with the fall collateral compromised, and with the pressure effect of the subdural hematoma, she developed the infarct. So vasospasm is not solely vasospasm, but because she's having compromised blood channels, that's why she had this stroke.
Okay, so I know it sounds it's actually a very tough case. It needs much more time to discuss. Just for the sake of time, we're 12 minutes past 9. I'll move to Dr. Derek to present our speaker.
Yeah, thank you, Dr. Al-Kuwaiti, for moderating this interesting case. And we have a delicacy for the end of this session, and it is a pleasure for me to introduce my friend Carlos Molina from Barcelona, who has been the chair of the stroke unit at Vall d'Hebron Hospital for more than 17 years. He has considerable experience in the diagnosis and treatment of acute ischemic and hemorrhagic stroke, and is recognized as a well-known leader in reperfusion therapies for acute stroke and secondary stroke prevention. Moreover, Professor Carlos Molina has conducted several important multi-center clinical trials and prospective registries for acute stroke in Barcelona. He has more than 460 papers in peer-reviewed journals, an H index of 56, mainly in the field of non-invasive evaluation of reperfusion in acute stroke using transcranial ultrasound. Carlos Molina is section editor of the Stroke Journal and a member of the executive committee for several stroke trials on acute stroke and secondary stroke prevention. Carlos, the floor is yours. Welcome.
So thank you very much. Thank you very much for the nice introduction, and thank you for the invitation. So I'm going to share my screen. I hope you can see it. Yep. Okay, thank you very much again for the invitation to participate in this MENA Stroke Organization webinar series. So it's a real pleasure for me to be here and share with all of you our experience and a summary of this topic, which is a hot topic, which is the comparison between bridging therapy. It means IVTPA plus mechanical thrombectomy versus direct thrombectomy. So in acute ischemic stroke, from trials to clinical practice. So, yeah, this is my disclosure. So this is the agenda for today's presentation. So first we will go for the rationale of skipping IVTPA. There is the idea, especially for some interventionalists, some very active centers, high volume centers, that it's better to send straight the patient to the angio suite, not for saving time and improve the safety of the procedure, but they forget that the basis of IVTPA and of the benefits of mechanical thrombectomy is based on TPA in patients who are otherwise candidates for TPA. So there are published randomized controlled trials comparing head-to-head direct transfer to the angio suite and direct thrombectomy against TPA plus mechanical thrombectomy, the so-called bridging. We will go through the preliminary results of unpublished randomized controlled trials, summary of all of this, and what the study level meta-analysis tells about the recommendations of what to do or where to go. So first, why skipping TPA? So TPA, as has been for years, the driven for stroke units development all around the world. The concept of time is brain is based on the implementation of IV-TPA. IV-TPA is very useful. However, there are some centers that, since the mechanical thrombectomy is becoming more and more available, so that seems that going the patient straight to the angio suite and skip TPA from the equation, this could be a good idea. So the basis, the rationale behind that is that this low recanalization rates of patients with large vessel occlusion treated with IV-TPA, which is around 10 to 30%, this is true. And these studies are based mainly on transcranial Doppler, so the rate of complete recanalization with IV-TPA, complete recanalization, is about 30%, and it's even lower in patients with T occlusions, for instance. On the other hand, so those who defend direct thrombectomy, they think that there is an increased risk of intracranial hemorrhage. There is a fear that the combination therapy will increase the risk of hemorrhage and then the safety of the procedure. Also, there may be a potential risk of clot dislocation and distal embolization during the procedure, so the clot will be more fragile to be dislodged and promote distal embolization during the rescue procedure, and also increase the cost of the whole procedure. TPA plus mechanical thrombectomy. This is another argument. Other arguments are in favor of they say that maybe this combination therapy may delay the initiation of the endovascular procedure. This is not true at all, because you can do things in parallel. So it's a parallel process of care in terms of sequence process, that TPA, door to needle, and then needle to groin. So you can do the things in parallel and organized in a parallel manner. And also there is a fear that if you have a tandem occlusion and you have to put an stent in, so this limits you to start dual antiplatelet therapy because you have TPA on board. On the other hand, there are defensors of bridging therapy. First of all, thrombolysis may have recanalization rates. So the thrombus itself can be softened and more fragile for mechanical thrombectomy. So the chances of first pass TK3 are higher in the combination therapy compared to thrombectomy alone. On the other hand, there would be, you can do as I mentioned, parallel process of care, so you can implement the TPA while the endovascular clinic is moving forward and prepare the thrombectomy procedure. And also, most importantly, TPA is the standard of care in the 4.5 hours time window. And the basis, all the clinical trials on mechanical thrombectomy that mechanical thrombectomy has demonstrated to be effective are based on IV-TPA. So, however, there are recently published randomized trials comparing head-to-head mechanical thrombectomy versus mechanical thrombectomy plus IV-TPA, the so-called bridging. This slide shows the recently published data in the last couple of years, 2020, 2001, these 4 trials comparing head-to-head bridging therapy versus mechanical thrombectomy alone, the DEPT trial, and the direct MT trial, were trials performed in China, the SKIP trial in Japan, and the Mr. Clean no IV in Europe. As you can see, there are differences in the number of patients treated in different trials. So this is a large data set in direct MT performed in China, Mr. Clean non-IV, more than 500. So around 200 in depth, and SKIP, all of them are published data. This slide shows the comparison of this data. As I mentioned before, so direct IT and depth trials were performed in China, the Mr. Clean no IV, in France, Belgium, in the Netherlands, as part of the Mr. Clean group, and in Japan, the SKIP trial. So all of them were designed as a proof design for non-inferiority trial, not for superiority, for non-inferiority, meaning that the hypothesis was that mechanical thrombectomy alone was not inferior compared to TPA plus mechanical thrombectomy. So the intervention, as you can see, was mechanical thrombectomy plus 0.9, except for the SKIP trial in Japan, they use 0.6 milligrams per kilogram of IVTPA, the population older than 80 years old, and patients within the first 4.5 hours of stroke onset. All the variables were comparable, less distal occlusions in the DEPT and the SKIP trial, no N2s, and more restricted, more favorable aspects values in the Japanese study. So this slide shows the main results of these 4 studies. And as you can see, the non-inferiority boundaries were achieved in these 2 trials, in the direct MT and the DEPT trial, both performed in China. But you can see here, the threshold for non-inferiority was very generous in the case of the DEPT, 10% differences, and the case of direct MT was 0.8, is 20% for non-inferiority, and they achieved 0.81. So it's roughly significant for non-inferiority. The other 2 trials didn't achieve this boundary for non-inferiority. Also important to mention that there were no differences in the safety, and importantly, the last bar showing the door-to-needle time. It is a good metrics that how TPA teams behave. And you can see only the Mr. Clean has a very acceptable door-to-needle time in this trial of about 30 minutes compared to almost 1 hour in direct thrombectomy and direct MT and in DEPT, and also in the SKIP trial. It means it goes against the IVTPA plus mechanical thrombectomy arms. What about unpublished data? Well, these are the data that is about to be published, the SWIFT Direct, 400 patients, and also the Direct SAFE, performed in China, Vietnam, Australia, and New Zealand. Also, the design was for non-inferiority of mechanical thrombectomy alone versus bridging, so to be acceptable non-inferiority boundaries. And as you can see, these studies has been already presented in the World Stroke Congress in 2021, and also in the European Stroke Organization Congress in 2021. And you can see, in the case of SWIFT Direct, there was a higher rate of recanalization, the successful recanalization. However, there was an increased risk of symptomatic intracranial hemorrhage in the same group. Mortality was comparable. So the main summary of all these randomized trials compared head-to-head, this is the evidence, mechanical thrombectomy plus IVTPA versus IVTPA alone, show there was non-inferiority in these 2 Chinese trials. However, with this limitation of the statistical criticism for this boundary for no inferiority. And in Europe, what we have is that in the SWIFT Direct, there was a higher rate of successful recanalization that is accompanied with an increased risk of symptomatic intracranial hemorrhage in the MT alone group. However, there are these meta-analyses that show these results. As you can see, the good outcome, as you can see, there was no difference in the proportion of good clinical outcome comparing bridging versus mechanical thrombectomy. Mortality was comparable. And there was a trend toward an increased risk of symptomatic intracranial hemorrhage in those patients treated with IVTPA, mechanical thrombectomy alone. So what's the conclusion? The conclusion is that today there is no strong evidence supporting skipping TPA. Skipping TPA is still the first line of treatment. Actually, we have a protocol in Barcelona that is called one-step stroke. Patients go straight to the angio suite, but even those cases, patients receive IVTPA. So TNK is an option, of course, but TNK is still under investigation. We are running also a trial comparing TPA and TNK in head-to-head comparison. So we'll speed up the process. You don't need perfusion, so it's very promising, but still under investigation. There are some cases, some scenarios where mechanical thrombectomy alone is a better option. For instance, for patients that we know that they have a carotid stenosis, and we plan to put an stent in right away. Probably this is the case. Or the case will be those patients at high risk of intracranial hemorrhage, inherent high risk of intracranial hemorrhage, and you have the angio suite available. No, there is no waste of time. So individual patient meta-analysis, the existing randomized for those trials are underway. So probably in the near future, we have more data. And also the benefits of the mechanical thrombectomy and the bridging therapy in general is more not on skipping TPA, but improving the performance of TPA, shorter door-to-needle times, implementation of pre-hospital IV TPA, implementation of telemedicine networks, and we can deliver TPA remotely and then transfer the patient for the endovascular centers. And also there are ongoing trials using novel thrombolytics like TNK that is demonstrated to be non-inferior. However, the implementation is not regular in all the scenarios. So the resilient direct TNK trial is ongoing. The TNCAT that we are performing in Catalonia is also ongoing, and the TNK plus trial is also ongoing. So finally, I have a case for you. This is a real case. This is a 43-year-old woman presenting with aphasia and right-sided hemiparesis. The NIH stroke scale score was 9. And the emergency room admission was at 175 minutes after stroke onset. Of course, this is the imaging performed. The CT, plain CT was normal. So there was a branch occlusion in the left middle artery. You can see here the perfusion deficit. Of course, an excellent candidate for IV TPA. She was in the window, and the door-to-needle time was very fast, was 20 minutes. So the resident of neurology was on call. So after treatment, so start infusion, and well, let's do a carotid ultrasound. And he performed a carotid ultrasound. This is this one. He shows this image, a floating clot in the ipsilateral carotid artery, 25 minutes after TPA bolus. So he freaked out and actually called us in the middle of the night, the rest of the team. So there were several questions, what to do in this case, what would you do? Well, he thought, well, why not stop TPA? Because there is a risk of dislodging the clot, and this distal occlusion will be a proximal occlusion, will be a disaster, and we turned a distal mild patient, which probably will respond to IV TPA, to a very severe stroke patient. Or the other option is skip the TPA infusion and close monitoring in the stroke unit. The third option would be called interventionalist for emergent angioplasty and stenting, or called interventionist for emergency balloon angioplasty, or called to my lawyer because I'm in trouble. He always said was the words of the resident. So we come down here and we talk to him and we explain that the evidence that we have on those cases with floating clots is limited, of course, but some studies have demonstrated the risk of dislodging the clot and create a proximal occlusion, a distal occlusion from this carotid floating clot is relatively low when TPA is on board. So you have to keep the TPA infusion. The only reason to stop TPA infusion is safety. Is in the case of intracranial hemorrhage. If during closely monitoring the patient suffering a recurrent stroke, you have to be ready and prepared for thrombectomy. What would happen if the patient, instead of a distal occlusion, have a proximal occlusion? In that case, we will go for endovascular treatment directly, even if TPA is on board, because the situation is completely different. So the risk of further embolization is not compensated by the risk of dramatic clinical worsening. So in that case, we will go for endovascular treatment. So the main message is keep infusion, control the patient. If the patient, instead of a distal occlusion, had a proximal occlusion, in that case, we will go for endovascular treatment and put in a stenting and rescue the patient. And that's all. And thank you very much for your attention. I hope you have questions for me about this difference between the comparison between bridging therapy or mechanical thrombectomy alone and about the case. And actually, I enjoy very much the cases you presented today.
Carlos, thank you. Thank you for this nice, passionate presentation. Let me start with one question from the audience. Rasha Ibrahim is asking, in patients receiving TPA that are going for embolectomy, do you discontinue TPA when you start the mechanical thrombectomy, or you continue the full dose?
No, we continue the full dose even in the case that we achieve TK3, because we have, in some cases, we have reocclusion. In other cases, when we perform post-perfusion thrombectomy, even in TK3, we can see a spot of distal perfusion deficits. So it's a distal migration of small clots that you cannot identify on angiogram, but you can see that on perfusion maps. So that's why we always keep the TPA infusion.
Okay. Any other questions from the audience? I don't see any here. It was a clear presentation. I just want to ask you, or I push you a little bit on this one. If you bridge, I understand that bridging is, something that you want to, bridge from one institution to another, or from the stroke mobile, CT-based stroke mobile to the angio suite, and I think this is what I would call bridging. But if you actually bridge with a door to needle time of 20 minutes and a door to groin time of 50 minutes, I don't think the TPA does really much, and I wouldn't really call it bridging. I think it's a simultaneous therapy or something like that, and it may be better or worse, but it looks like from your data that it is pretty much the same, isn't it?
It's not exactly the same, and you're right. It's in some ways simultaneous. For instance, those patients who go straight to the angio suite, and we don't skip TPA because, for instance, for all patients, it's sometimes a nightmare to navigate in an hostile aortic arch, and you spend time just navigating there, not getting the clot, and you start thinking on TPA. Where is the TPA? Because we skip it. So that's why, and you are right. The proper bridging term was coined because of this sequential process that you start with TPA. If the TPA didn't work, so you go for endovascular. But this is nowadays we have to do like this. TPA plus endovascular treatment. And you're right. At some point, you have this overlap. It's not that bridging is like overlap the treatment, but still, I think like 15% of our patients, bridging patients, are like this. Our patients that are in the ER, but many things happen in between. Sometimes in the middle of the night, the interventionalist is not on site, has to come from home. So that is, and in that case, we have bridging. In other cases, it's like this. It's exactly like this. Patient goes straight to the angio suite. Actually, now we have a program called One Step Stroke. So the ambulance transfer the patient directly to the angio suite, and we perform a dyna CT just to rule out hemorrhage. It's the ideal case for direct thrombectomy, but even in those cases, still, till we demonstrate the gains, the patient receive TPA. Probably in the future TNK, but for now it's TPA.
But Carlos, if I remember correctly, this was a paper published in JAMA last year. And I think, if I remember correctly, please allude to this. You saved 15 or 20% of the time by doing this, and your outcomes, giving this very small trial, were already better. So, can you comment on this a little bit more for us?
Yeah, it's direct transfer, not direct thrombectomy. It's direct. The paper we published in JAMA Neurology was about direct transfer to the angio suite, not direct thrombectomy, which is different. Direct thrombectomy is send the patient to and skip TPA. We send the patient to the angio suite, but the TPA in most of these cases were still on board. The patient were candidates for TPA. So this is different. It is the saving of time, increasing twofold the probability of good clinical outcome, just for improving the process of care, just to shorten the process of care as soon as possible. That's why I think our responsibility is at a system level, a systemic level, as a regional level, to improve the network, to transfer the patient for a comprehensive stroke center.
Okay.
Derek, I have a question.
Yes, please go.
Prof. Carlos, thank you for this great review. I just have a question regarding why did the Chinese trials, the two RCTs were non-inferior and the others were negative? Is there an explanation from your expertise?
So there are two major points. One point is the generous boundary for non-inferiority. So it's 80% is very low. It's not 90%. It's so easier to get this lower boundary. And they achieve actually in the direct MT 0.81. So very roughly. This is one explanation. And the other one is that the time for TPA, the door-to-needle time, the performance of TPA this time was very long. Was almost 1 hour. So in the Mr. Clean no IV is a European standard. It's about 30%. So it means TPA was very efficiently performed. The performance of TPA was very good, 30% instead of double, 60%. It matters at the time of improved recanalization rates and outcome. I think this is one of the reasons.
Mm-hmm. Yeah. Here's another question from the audience. Carlos, they were impressed by the use of the ultrasound so early. Do you do this routinely or?
Not anymore. Actually, not anymore. I have to be honest. Because if you have CTA, go for CTA. If you have CTA, I'm an ultrasound guide for years. And I have to accept and to move forward that now if you use center, you have CTA is reliable, it's fast. You can see the proximal occlusion. Ultrasound is useful for monitoring patients, for monitoring recanalization in the angio suite or even in between TPA and the endovascular. While the endovascular team is preparing the endovascular procedure, you can monitor the patient with TCD and see if the patient has a recanalization with TPA, because up to 10 to 15% of patients recanalize, proximal occlusion recanalize before endovascular treatment. And with TNK, it has been demonstrated that the rate of pre-interventional recanalization is higher with TNK compared to TPA. So this a way to demonstrate that is ultrasound. And also ultrasound gives us information about reocclusion, which is very important. And it's not that easy to recognize because in some cases there is a delay between recanalization and clinical improvement. The patient is still with a clinical deficit for hours after complete full restoration of blood flow, and you don't know if this is just because of there was a large infarction in the background or there was a reocclusion, and TCT in that scenario helps a lot to see how the vascular status is.
Can you comment on this? You have done a lot of work with ultrasound, and you said, well, a lot of this work is now being taken over by CT angiogram, just for the ease and also standardized documentation. But what about if you have a patient, for example, that you bridged or simultaneously treated, and then the patient is in the cath lab and everything's open, so you don't do anything anymore. How do you monitor, or do you monitor these patients in the ICU with TCD, either with a helmet or with discontinuous examination? Is that something that you do?
Yeah, in some cases, especially in high risk, in patients at high risk of recurrence of reocclusion, in particular in patients with carotid pathology, lateral carotid stenosis, that for instance, we go for the M1, we decided because of the size of because of the aspect value at baseline, we decided not to put the patient on dual antiplatelet therapy, don't deploy it and stand just an angioplasty and pulling out the clots and retriever. And then we postpone the definitive stenting and dual antiplatelet therapy when TPA is not on board, like 48 hours later. In that case, a specific case, we monitor the patient continuously with TCT just to check whether there is a subclinical embolization that we can see of the patient still with the clinical deficit. That so the clinical deficit doesn't guide us how to manage the patient. So ultrasound is very useful in that scenario.
Very good. Fatima has a question here. Excuse me, sure. One more question. What are the contraindications for the use of TPA in this model of simultaneous treatment? Is it how do you balance, for example, a patient with an active bleeding or with a high bleeding risk, and which are the ones that you would not treat with IV TPA before a thrombectomy?
So beside the conventional contraindications such as anticoagulation and so on, if you have a patient, for instance, who have a history of intracranial hemorrhage plus dual antiplatelet therapy plus in the limit of the time window plus and more plus that are not by itself, by separate, they are not contraindications, but pulling all them together maybe is a good contraindication. So that case, we realized better go straight to if the angio suite is available, go straight to mechanical thrombectomy. Is what we call the common sense contraindication. It's not just putting single contraindication, but all together. The patient is a bad patient, but you know it's going to bleed. So the risk of bleeding is high. Beside the formal contraindications, otherwise, for IV TPA, such as anticoagulation, for instance.
Mm-hmm. Anybody else from the panel or audience? More questions for Dr. Molina?
I do have a question.
Sure.
It's in my practice, I try to give a TPA unless there's contraindication. I wonder if, for example, a patient didn't take TPA and then went for the procedure, and then there was a difficulty in opening the vessel. What do you do next? Would you give IA TPA, or would you just stop there? Or
this is a great question. Actually, this happened to us sometimes when the patient goes straight to the angio suite. No, TPA is skipping for different reasons, for instance, contraindication or no contraindication, just these high-risk patients. So once you are in there, so another option is intraarterial rescue. For instance, we recently published the CHOICE trial, so other trials are preparing and will come up in the future, such as the TECHNO trial, just delivering intraarterial TPA. It was the choice, and we demonstrate a higher rate of post-perfusion, reperfusion, in the post-perfusion study, higher rates of reperfusion in patients with incomplete recanalization. Even those patients with TK3 may have spots of lack of perfusion. So in those cases, also rescue with IV TPA can be given. This is true that patients on oral anticoagulation were not in that trial, but for patients with incomplete recanalization is an option, the use of intraarterial lytics for rescue therapy. Otherwise, the limit of treated patients with thrombolytics. Probably in the future, also the combination of neuroprotection, better neuroprotectants that failed in the past may have a room now in the future, even hypothermia and other procedures.
What is the dose of IA TPA, Carlos?
That's a perfect question. Yeah, we don't even know, actually, to be honest. So in the trial was a 0.1 milligram per kilogram. For the TECHNO, they're gonna use just 1 gram of TNK. That is, I asked the questions for the sponsors. Why do you choose this? Did you choose this dose? And I had no clear answer, because we need a dose escalation studies, proper dose escalation studies, to see what's the safety of this doses, intraarterial doses of both TPA and TNK. But I don't have the right question, the right answer. Sorry for this question.
Okay. And for the IA TPA, would you extend the time window to like 6 hours or? Yeah,
probably because you are in there. In most cases, you are going to be beyond 4.5 hours when you are in there. It's in particular for those in the time window, but some of them in the choice were outside the time window at the time of delivery, actual delivery of IA TPA. But still, this is a field that is just started to be explored, is under investigation, is not recommended for clinical practice. It has to be into clinical trials still.
Great. Yeah, I don't see any question anymore here. There's one. What is the percentage of patients that improve on RTPA alone? I guess that's a tough question to answer.
Yeah, based on the results of clinical trials, when compared with mechanical thrombectomy, it means the control arm receiving TPA is about 22 to 25%, up to 30%. It depends on the case mix. You have more patients with large vessel occlusion, the rate of recanalization of good outcome is lower. You have patients with distal occlusions, for instance, in the trial, the NOTES trial comparing TNK versus TPA, the rates of good outcome were higher than 60% because most of them were relatively mild stroke. If you have to categorize your case mix, and mild strokes is about 60%, moderate stroke is about 40 to 50%, and severe stroke is about 20 to 25%.
And here's one question about comorbidity, neurological comorbidity. So if you have a patient with an old CVA and let's say a contralateral hemiplegia, is that a contraindication, or do you go in these cases?
So it means the patient previous quality of life. So is the previous comorbid status of the patient is a contraindication. I think we have to individualize this. Actually, the European guidelines recommend to treat patients even if they have disabled, because if we have to individualize the decision making, because if we have a patient who is paraplegic, for instance, is paraplegic for a car accident, for instance, so he has a ranking of 4. So, but he has another functions that can be saved by reperfusion. So this patient is an excellent candidate for reperfusion. If I have a patient 90 years old, previous stroke, severe disability, ranking of 3, probably is a candidate still for TPA, but not for mechanical thrombectomy. So we need to individualize depending on the case by case.
And here's a question of someone who really wants to know the gritty details. Carlos, when you're pretty aggressive in your approach, and the question here is, how many of your patients have to undergo a decompressive craniotomy after treatment?
So this is a very good question. Actually, before mechanical thrombectomy era, so the numbers per year in my center was about, we were checking that the other day, was about 22 to 25 cases per year. In my hospital, we attend 1,800 stroke patients per year. So 25 receive hemicraniectomy, younger than 60 years old, large massive infarction. But now it's less than this. And thanks to thrombectomy, I think these numbers are no more than 10, 12 per year receive mechanical thrombectomy. Actually, we have a protocol in our hospital, even for those patients with large core infarctions, that they go for endovascular treatment because we have clinical trials for large core infarctions. And this, after the procedure, we perform an MRI. The MRI shows you an infarct volume higher than 80 to 100 cc, so the patient goes straight to the hemicraniectomy. But the numbers has dropped a lot of the last years. I think it's thanks to mechanical thrombectomy that avoid the evolution to malignant MCA infarction.
Okay. One of the last questions here, I think a very good one. What about pregnancy? How does pregnancy change your decision making?
This is another excellent question, and it's not easy. It depends on the phase of the pregnancy. It is at the beginning or the end of the pregnancy. So in general, there is no formal contraindication, neither for TPA nor for mechanical thrombectomy for pregnant patients. So if the patient has a proximal occlusion, I will go for mechanical thrombectomy for sure, especially if they have a risk of bleeding or to lose the baby. So in that case, we go for mechanical thrombectomy, straight to mechanical thrombectomy. For IVTPA, there is no, of course, these patients have not been included into clinical trials, so all the experience is based off case studies. So the pooling data point out over to treat the patient with IVTPA if these patients have no contraindication. But this type of decision, again, has to be individualized depending on the risk of bleeding and the phase of pregnancy.
Yeah. Any predictors for symptomatic intracranial hemorrhages secondary to IVTPA?
So the main predictor is the size of infarction. I think is the main predictor of intracranial hemorrhage. I think of the last years, I remember the last decade, we were very focused on the risk of intracranial hemorrhage. It was moved by our fear to intracranial hemorrhage, but now if you endorse the guidelines, really endorse the guidelines for IVTPA, the risk of intracranial hemorrhage is relatively low. Mainly if you have a large infarction, you have high risk. If you didn't check properly the hypodensity and you consider this is just a small hypodensity, if you see hypodensity, the patient will bleed for sure. It's different early signs of infarction than hypodensity. You know, we can, even if the patient say, or the family says, oh, okay, it's just 3 hours after stroke onset, but we see hypodensity. So they lie. Sometimes they lie. This happened, at least in Spain, that the patient, the families, they say it's just 3 hours. No, it's more, because the CT scan is telling you that it's more than that. I think this is the main reason, and blood pressure. Blood pressure management is critical in TP. And that's why we have to implement stroke units, to put the patient in the stroke units for very accurate and aggressive, in some cases, blood pressure management.
Yeah, I think that's important, and we discussed this in the first cases as well. The post-treatment is also very important. It's not only, opening that vessel, it's also to keep it open. Carlos, I think this was it. Maria?
I hate to cut into this very interesting conversation going on. Thank you, Professor Carlos. I think it was an amazing session. We started off with 3 interesting cases. The role of mechanical thrombectomy in low NIHSS large vessel occlusions. That was followed by MR-based selection of patients for mechanical thrombectomy in the absence of perfusion imaging. And then we had an interesting case by Dr. Jay, where we diagnosed the patient with CNS vasculitis. A lot of discussion, of course, and a lot of queries are still unanswered for that question, for that particular case. But the role of vessel wall imaging was very nicely presented by Dr. Saeed Iqbal. And I'd like to thank Dr. Carlos. It was a very, very nice review of the recent literature on this bridging therapy. Thank you, Dr. Dirk and Dr. Kuwaiti, for the wonderful input throughout these sessions. I think we are just in time for the 2 hours are up, and I'm sure everybody's going away with some new information, some new knowledge, and till we see you all next time.
Hello, hi Maria, hi Carlos, Derek. This is Suhail from Dubai, President of MENASO, and I would like to thank all of you